Hello, everyone. Happy holidays from WEDI. I'm Michael McNutt, Director of Education and Events, and welcome to our virtual spotlight, Lessons Learned from a Ransomware Attack. A little bit about WEDI. Formed nearly 30 years ago, WEDI has been an instrumental force in igniting public-private partnerships to empower meaningful changes for the American healthcare system. Recognized and trusted as a formal advisor to the Secretary of Health and Human Services, WEDI is the leading authority on the use of health IT to efficiently improve health information exchange, enhance care quality, and reduce cost. With a focus on advancing standards for electronic administrative transactions, promoting data privacy and security, WEDI has been instrumental in aligning the industry in an effort to harmonize administrative and clinical data. Affecting change through consensus. Now, how do we do what we do? So through a variety of different outputs, our work groups and sub-work groups, which you'll learn about shortly, our task groups, open public forums, conferences and virtual spotlights like you are attending today, and our policy advisory groups, also known as our member position advisory groups. Our members represent every facet of the nation's healthcare industry, including practitioners, hospitals, state organizations, health plans, laboratories, government entities, clearinghouses, vendors, standards organizations, and other valued stakeholders. The strength, lifeblood of WEDI is through our work groups, volunteer organizations providing thoughtful leadership and common sense approaches that enhance the exchange of clinical and administrative healthcare information. Our work groups produce white papers, briefings, advise and assist with WEDI education. Some of them are listed here below, including payment models, data exchange, dental, telehealth, and privacy and security. And with that, I'd like to introduce Marilyn Zigman-Luke of AHIP, who serves as WEDI's Privacy and Security Workgroup Co-Chair, along with her colleague, Tina Grande, from the Healthcare Leadership Council. Welcome, Marilyn.
Michael, thank you for that nice introduction, and welcome to everyone who's joining us for this important event today. It's my privilege to be part of the WEDI Privacy and Security Workgroup. And in partnership with Tina, who will be joining us later in the session, we get involved with a number of what we'll call hot topics in privacy, security, cybersecurity, and our work really is vast and covers federal legislative issues, federal regulatory issues, and we also monitor things that are happening in terms of the private sector as well as state developments. The goal of the work group is to really bring together professionals across the industry to work toward resolution on implementation issues. We primarily focus on securing and protecting health information, but we also facilitate the review of privacy and security and deal with requirements. Many of you may know the HIPAA privacy and security rules, the Health Information Technology for Economic and Clinical Health Act, or the HITECH Act, and a number of other opportunities that have come up with respect to interoperability and making medical records available, whether that's through an electronic health record, through health information exchanges, and a variety of other modules and forums. I would encourage those who are interested in joining our work group and who want to at least be part of our discussions and help with some of this work in terms of monitoring what the top issues are and getting involved in some of the advocacy and educational events, please contact Samantha Holvey at WEDI. Her email is listed on the slide set, and she'd be happy to connect you to the work group and give you a copy of our schedule and our upcoming events. In terms of our agenda today, we have slotted a number of important updates, and I think what you're going to see is that we've got a really robust and set of great professionals who are going to talk about, from a very substantive perspective, but also a real life practical perspective, what they've dealt with in terms of ransomware and how we can all leverage their experiences and their knowledge for our own day-to-day lives. We're going to start off with the threat and mitigation update, and I'm happy to say that we have Nick Rodriguez with us. Nick is the program manager of what's called the 405D program and task force. And we also have Daryl Hall. He is the Cyber Engagement Specialist for the Health Sector Cybersecurity Coordination Center, what we all commonly know as HC3. Later this afternoon, we're going to hear about lessons learned from a ransomware attack. We have a number of medical professionals who will be joining us for that. And we'll also be talking in terms of a panel discussion later this afternoon about ways to strengthen cybersecurity in healthcare. So Michael and the WEDI team have really developed a very robust agenda for today. And I think, Michael, with that, we can go ahead and move on to the next slide. Just a snapshot of what's coming in January. This is also free to WEDI members. We are going to continue our educational initiative. And in January on the 31st, we're going to be talking about what's called the Zero Trust Identity Strategy and how that can help protect patient data. We have a leading author and policy advisor, Zachary Martin, who will be joining us for that. And so if you want to learn more about Zero Trust, what it is and how it might help, that certainly is a good opportunity for you to do that. Just a moment in terms of the virtual platform that we're on for our discussions today. It is very frequent that as we're moving through the presentation, you've got questions. We encourage you to use what's called the chat feature, which is available in the taskbar of the platform. And for those who are interested in getting a copy of the slides, and if your colleagues have been unable to join us today, we will have a recording available. Both of those will be emailed after the event. So with that, I think I'm going to turn it over to Nick and to Daryl, who are going to give us their perspectives in terms of cybersecurity programs from the HHS perspective. So Nick, why don't I turn it to you first?
Perfect. Thank you, Marilyn. And thank you, WEDI, for having us today. Both Darren and I are excited to be back at this forum, giving everybody an overview of the current threat landscape, as well as some highlighting some new products and resources from the 405D task group and program. So before I hand it over to Daryl, we're going to kind of set the stage. I'm sure as everyone's on this call is aware of cybersecurity in the public health sector. Continues to be a very relevant conversation amongst many organizations. As you can see from the stats across the board, cybersecurity in the healthcare and public health sector continuously sees increases, whether it's from phishing attacks to ransomware or to other types of attacks. Most recently, I'm sure everyone's familiar with the Common Spirit attack that was this past October. It has come out and details are still continuing to highlight that the vastness of that cybersecurity attack. But most recently, OCR did put out some findings at the beginning of this month that research is already showing that from that attack alone, over 600,000 compromised protected health information, PHI data was impacted by that. And as of November 9th, so about a month ago or so, not all the entire patient records, patient portals, and online systems were back up and running for that organization. So ransomware is a huge topic for our sector, and that many of us are continually battle and looking for resources and best practices. So next slide, that's kind of why we're here at HHS. We're partnering with the public health sector in a host of ways across the broad spectrum of HHS. But today we're going to highlight two programs specifically within OIS. That's the 405D program and the HC3 program. I believe many of the WEDI members here are familiar with our programs. So we're going to kind of just do a brief highlight of new resources that each program has, and Daryl is going to jump into it with a deep dive into the most recent ransomware attacks that we're seeing for the sector. But we're really excited again to be here, so thank you for having us. If you have any information or would like additional information, both HC3 and 405D contact information is not only on this slide, but you'll see it in the following slides. Please don't hesitate to reach out to us. That's what Daryl and his team and my team are here for, is engaging with you guys on one-on-one, or happy to support you in any way we can. So again, thanks for having us. And with that, I'll hand it over to Daryl to get us started.
Next slide, please. So, hello, my name is Daryl Hall. I'm with the Healthcare Sector Cybersecurity Coordination Center of the Department of Health and Human Services. And many of you are familiar with me already, but today I'm going to present you an overview of HC3 and a current threat brief focusing on the Hive ransomware group. In recent months, they've had a major impact on the health and public health sector. For those of you that are not familiar with HC3, however, I'll give you a quick introduction. HC3 provides the HPH sector with awareness of ransomware threats and mitigation tactics to reduce risk. We take the larger set of attacks and risk updates and curate it to produce meaningful products that can be used by the sector. We regularly release threat briefs on ransomware trends and consistently release products to update the HPH sector on new and emerging trends. HC3 has also worked with the Cybersecurity and Infrastructure Security Agency, or CISA, and the Health Information Sharing and Analysis Center, HISAC, to produce joint SIL products. Next slide, please. So some of the observations of the Hive ransomware group. So they were first observed in 2021. According to the FBI, it's likely that Hive operates as an affiliate-based ransomware. This means they use a subscription-based model that enables affiliates to use already developed ransomware tools to execute ransomware attacks. The affiliates then earn a percentage of each successful ransomware payment. The Hive ransomware group is known to use a double extortion technique. This means they charge an organization to get the decryption key. Once that is paid, then they charge the victim to not release the impacted data. They're known to use human-operated attacks, which are the most dangerous. This means the attack is targeted, and there's a set of hands on the keyboard during the actual attack. Indicators of this type of attack are credential theft and lateral movement within the network, which we'll see later. Part of their TTPs are to use legitimate commercial security assessment applications to find vulnerabilities. But again, we'll dive into that later in the slides. As of late, the Hive ransomware group has been using ransomware software that is not open source and is compiled to affect both 32 and 64-bit operating systems. This use of custom software shows a maturity to the group, giving merit to the HPH community's growing concerns of this group. There's also been indicators that members of the Hive ransomware group are Russian-speaking. Next slide, please. So some of the observed TTPs that we're going to talk about of Hive are the use of legitimate commercial applications, as we mentioned before. These are tools such as Cobalt Strike, which a number of us are familiar with. It has the capability to be a malware dropper or to be dropped by other software and then used as the primary malware to pivot around inside of a network. It is also capable of being used in conjunction with the Metasploit framework, which has been documented extensively by organizations such as Malwarebytes Labs, and is also used by both white hat or black hat hackers or red teams and blue teams, depending on what term you like to use. Another tool that they like to use is ConnectWise. It's listed as a self-hosted remote desktop software application. It can be used for file transfers, screen recording, command line access, and also reconnect connections that are broken, helping them maintain persistence while the attack is actually going on. It can be used on Windows, Linux, Mac, and iOS devices. It also allows traffic to be encrypted with AES 256, blinding defenders to what the traffic actually is. The last major legitimate tool we'll talk about is AdRecon, or Active Directory Reconnaissance. It's used to pull information out of the Windows Active Directory. This includes, but is not limited to, user attributes, the OU structure, BitLocker recovery keys, or computer attributes. It has the capability to be deployed by PowerShell and is available publicly for download from GitHub. The Hive ransomware group has begun deploying malware that was developed in-house. What we know about it is originally the malware was written in the Go programming language, which is easy to write, but produces incredibly large executable files. This is where the UPX tool comes in. The UPX software allows the programs to be compressed to a much smaller size, making it easier to upload during the infection phase and reduce the chance that it will be detected. Very recently, however, Hive has been observed developing their malware variants in Rust, only the second ransomware group known to do this. This makes it resistant to reverse engineering and also allows access to control of lower level resources, expanding its access to the cryptographic libraries. Next slide, please. To gain initial access, the Hive ransomware group has been observed using a combination of phishing emails, exploitation of public-facing applications such as Microsoft Exchange, or poorly protected single-factor remote network connection protocols such as RDP and VPN services. After gaining access, the Hive ransomware group will attempt to begin collecting credentials, again showing that this is a human-operated attack. This is done by grabbing a full copy of the LSAS dump files using the commands listed in the top box here. Another technique they will try is to enable the WDigest service. This means the system will cache credentials in memory, making it much easier to harvest credentials. This can be seen in the second box, where the registry key for use logon credentials is enabled or set to 1, and then forced to take effect on the compromised system with the GP update command. Then they will use a tool such as Add Recon to enumerate the victim's Active Directory environment, looking for critical OU structures, group policy objects, computer attributes, user attributes, domain accounts that may be used for service accounts, which are rarely monitored well, and pertinent DNS information. Next slide, please. Next, the Hive ransomware group will begin by removing the anti-malware software, so your antivirus or your anti-spy software. Then they will stop the ability to back up or restore files. One of the services they've been observed attacking is VSS, or Volumes Shadow Copy Service, which is current Microsoft products, which allows backups of data to be made while users continue to use the system. Next, they will remove those VSS copies, further limiting the chance the data can be restored without paying the ransom. Next, they will then look for database software that is running and attempt to stop it. This may be an attempt to stop the logs from being recorded somewhere outside of the Windows logs. Database services that have been observed being targeted by Hive are Microsoft SQL, Oracle, Postgres, and Redis. Next, the Hive ransomware group has been observed deleting the Windows system logs, security logs, and application logs. We're sure this is an attempt to keep their actions hidden before the ransom software has time to fully complete what it's doing. Finally, they will attempt to terminate the SSTP service, which is an SSL-based point-to-point tunneling protocol used heavily in Windows. It's favored by companies due to the use of port 443 and TLS security, and because it can traverse NAT firewalls, or network access translation firewalls. The actual ransomware software has been found to be named hive.exe and used in conjunction with a hive.bat file or batch file. It will attempt to encrypt all the files on the computer outside the C Windows folder. This means the computer will continue to work and be able to deliver the ransomware message. The lower graphic here shows the hive.bat file. It simply cleans up after the infection, allowing the group to go unnoticed until they finish their work and possibly reduce the chance that a forensics team can figure out what happened. Next slide, please. So I'll give everyone a moment to read over the message, and hopefully it's not too small. So the key takeaways are each victim will be notified that their data has been encrypted, standard practice, and then they will be given a Tor site to connect to. Each victim will get a unique set of credentials that they can use to make a payment to the Hive ransomware group. Lastly, victims are notified that if they fail to comply with their payments, their data will be released publicly. Next slide, please. So in this graphic here, we can see that the Hive ransomware group's first 100 days were very active. They had at least 5 attacks against the HPH sector in that time that were reported. And mind you, we're just talking about reported incidents. In this period, Hive was the 3rd most active ransomware as a service provider targeting the HPH or health and public health sector, led only by Conti and REvil. Since their inception, Hive has been very aggressive. Per statistics tracked by HHS and the FBI, between the dates of June 2021, whenever they were first observed, and November of 2022, they victimized over 1,300 companies and received approximately $100 million in payments. Next slide, please. So the Hive ransomware attacks are not limited to just the virtual world. The Hive ransomware has had kinetic effects on the HPH sector. This means there's been real world effects that affect people, or that affect machines and people. So there are reported cases of emergency rooms and urgent care units being closed, causing ambulance diversions. They've also caused cancellations of surgeries in some cases due to services like radiology being shut down. So the ransomware group does not seem to target specific types of data. More, they want to collect everything and hope they get a pot of gold that the victim will pay for. So in this list, we can see some of the types of data that we know they have stolen. And you'll notice the amount of data is quite a large range, given the nature of how hard it is to track attacks like this. So in the list, we can see they've collected medical records, financial documents, company proprietary work, company sensitive legal and insurance documents, employees' passwords and their PII, and even clients list, which are critical to some organizations. And mind you, they don't go just for HPH. Next slide, please. So hopefully everyone here is familiar with the MITRE attack framework. So some of the TTPs that Hive has been recognized using are gaining access to by the use of RDP or VPN services. Then they will attack external services like we spoke about, the Microsoft Exchange ones, particularly the CVE 2021-42321 and 2021-34473. Or they will use good old-fashioned phishing to get into the environment and create their initial access. Once in, they will begin to use defensive evasion. So they will stop the anti-malware, anti-spyware software from running, delete the Windows logs, and attempt to reduce the ability to back up software during the attack phase. And finally, they use the impact of encrypting all the software on the system, which is kind of what makes it ransomware. Right. So next slide, please. So again, my name is Daryl Hall. I'm with the Health Sector Cybersecurity Coordination Center. If you're interested in any more information on the subject or how we can work together, please contact me and my team at hc3@hhs.gov or find us on on the web at hhs.gov/HC3. At this point, I'll pass it back to Nick.
Great, thanks, Daryl. I think we're supposed to wait till the end for questions, but is there any questions off the bat in the chat or anything that we should address, Michael?
Hi, it's Marilyn. I'm checking. I don't see that we have any questions in the chat. So why don't you go ahead and we'll save any questions that we get for the end.
Perfect, great, thank you. Next slide. You can go to the next slide as well. So again, just to kind of level set for the group here, my name is Nick Rodriguez. I'm from the 405D program here at HHS. If you haven't heard of us, 405D is kind of the short name, but it's a 405D Aligning Healthcare Industry Security Approaches program. And really what we're set out to do is be the leading collaboration center for OIS and the HPH sector. So we're working with representatives from across the HPH sector to develop impactful resources, products, and tools that raise awareness and provide vetted cybersecurity practices. And the key part there is vetted security practices. So where Daryl and HC3 is providing all the threat intelligence and sector alerts and all that great data, 405B kind of fits on the other hand of providing the best practices that organizations can put in place to hopefully mitigate ransomware, for example, or email phishing, social engineering, etc. We're really hoping to drive behavior change. So our program is cyber safety is patient safety. And we're really working with organizations to provide them the content, both from mitigation practice, but also cyber awareness, products, education, etc. Next slide. So the cornerstone publication, if you haven't heard of it, goes by HICCUP, and that's short for the Health Industry Cybersecurity Practices, Managing Threats and Protecting Patients. That is a joint industry and HHS publication that outlines the top 5 threats facing the sector and then provides 10 mitigating practices to mitigate against those 5 threats. The publication is split up into 3 parts. The first one is the main document. It's very plain language. It's very easy to read and really highlights the 5 threats and why the sector really believes that these are the 5 threats that all organizations really need to focus on and get their organizations, mitigated against. The technical volumes, there's 2 of them. The first one is dedicated to small organizations, and the second one is dedicated to medium and large. Those are where you find the mitigating practices. So the 10 practices in total, as well as I think there's 89 or so sub-practices spread out throughout the technical volumes. So if you're wondering where you fall, which technical volume you should pick up, the first part is to start with the main document. There is a where do I fit organization chart where it kind of gives you some key demographics about your organization to really figure out where industry thinks you are and where you should pick up the technical volumes. But they're not in, one size fits all. So you may be doing some things in the small, but you're really looking to elevate yourself and therefore should be picking up the technical volume. So one thing that we have done to help organizations really figure out how to leverage and put in these mitigating practices is a tool that goes by it's called the HICCUP Mitigation Matrix. It's an Excel document. It's really easy to do. And you can do an assessment of basically where your organization is, and then it provides you the direct places in the technical volumes to find more content, more best practices, and more controls that you should potentially apply. It also does a great job of laying out the HICCUP practices against NIST as well as the CSF framework. So I highly, highly recommend that if you haven't picked up HICCUP and looking where to get started, to definitely leverage that tool. Next slide. So what we would really like to highlight in this call is we're hoping that many of you guys have heard of HICCUP, have picked up HICCUP over the last 2 years or so since it was first released, I guess now almost 3 years ago, is the 2022 edition. So over the last year and a half or so, the 405D task group has been working on updating HICCUP to ensure that the publication stays relevant and provides the sector with the most up-to-date best practices. This isn't a complete rewrite. Industry still strongly felt like the 5 threats were relevant and the most critical for the sector to focus on, with a slight variation to threat 1. Instead of specifically being dedicated to email phishing, they've expanded a little bit or a lot to cover now social engineering, just to get the sector, more aware of the other types of phishing attempts that are happening across the board, as well as cybersecurity practice is now being labeled cybersecurity oversight and governance. So we've kind of beefed up that section to include more information around governments and policies and all that good stuff. And then in addition, what we've added to the sub-practice you can see here is cyber insurance is now a sub-practice, cybersecurity risk assessment and management, attack simulations, as well as the medical devices sub-practice has had a fairly large update to it. So this publication is forthcoming. It's currently in HHS review right before publication. It could come out any day. We're really hoping most likely beginning of the year, but we're very excited that HICCUP is being updated. Industry has worked really hard over the last year, as well as just the sector at large, providing us feedback over the last 2 years, as well as feedback during this update process of what additional content is needed to make sure that HICCUP stays at the forefront of leading best practices publications and as a resource as all. So if you're not on the 405D distribution list, I highly recommend that you jump on that. You can sign up via our website, 405d.hhs.gov. And the moment that HICCUP is available, we'll be pushing out communications related to that. Next slide. I kind of covered this, I guess, in the previous, so I apologize. But you can kind of see there what the HICCUP 2022 overview is going to cover in terms of the top 10 practices as well. Next slide. So the other thing we wanted to highlight to this group, something new from the last time we spoke to you guys, was the passage of PL 116-321. This was an amendment to the Health Information Technology for Economic and Clinical Health Act, HITECH for short. This was passed at the end of 2020, I believe it was the actual date. So it's really been this past year, 2021. Okay, signed, there you go. So this past year, it's really taken off in terms of what this new law means for HHS and the impact for the sector. So in short, what the law did is it's calling upon HHS to recognize security best practices and approaches. And in that legislation, it specifically calls out the HHS 405D as being one of those recognized platforms or programs for best practices. I will highlight that OCR, I think, just wrapped up their rulemaking process or call for information for the sector about how to implement this. They did just release a video on how OCR is viewing this law, specifically how 405D examples fit into this new law and really what they'll be looking at if they were to be applying this new law in the event an organization is found liable, if they put in these best practices and how so forth that might impact their fines or their repercussions, etc. So if you haven't seen that, I also highly recommend you, it's a quick Google, just OCR, recognize security practices. Of course, like good old government, they're going by short, it's RSPs now. So check out that video. Nick Heasters is the individual on the topic. He is part of the 405D task group, so there's been some great synergies there. And we're really excited about this law, not only for HICCUP and the impact that it has for the sector, but also just the recognition of the program as a whole and the task group's efforts to really help align security approaches across the industry and really move that needle. So if you need more information about this law, please reach out to us. We're happy to connect the dots in any way we're possible, but definitely keep your ear to the ground on how this law matures and is implemented from OCR, as well as the additional new products coming out from our program and how this new law will impact those as well. Next slide. So just to highlight some of our program resources, just in case you have or new or you haven't heard of us. So in addition to the Cornerstone publication, Hiccup, the 405D task group is working on additional new official publications. One specifically is centered on cybersecurity and ERM, helping organizations implement cybersecurity across their ERM and integrate them. And the second is making the HSCC product, the OCCIO, the operational, I just blanked, OCCI, Oxy document. I think Lisa might be on, maybe she can put it in the chat box for me and save me, into an official product. But that's a checklist for in case of, operation controls, what to do, who to engage, how to communicate, etc. in an event of a cybersecurity attack. Both those will be official HHS products, which is great. So again, tying back to that law and providing hopefully some incentives for organizations to implement these best practices. And then in addition, highlighting our 405D awareness materials and outreach. We do have a newsletter that goes out bi-monthly that's in partnership with industry on a host of different topics, as well as a spotlight webinar where we engage with industry, have guest presenters, et cetera, on the different cybersecurity awareness products. Coming in 2023, we are launching an educational platform. It's called the 405D Knowledge on Demand, and that's going to be free cybersecurity training for stakeholders across the HPH sector. So we're really excited about 2023 and all the great products and resources that will be coming out and really helping the sector move the needle in cybersecurity and provide them the resources that are truly needed. So if you go to the next slide, I believe it's just our website and contact information. Again, our website, I am just skipping up. You can go to the next one. Just talked about those two. Our website is 405d.hhs.gov, where you can get the Hiccup publications, sign up for our communications distribution, as well as find all of our cyber awareness resources and tools, as well as follow us on Ask 405D across our media platforms. It's another great way to stay in the loop in terms of what 405D is doing and all the free resources that we will be putting out. Our email address is CISA405D@hhs.gov. So please don't hesitate to reach out if you have any questions or would like to get involved with the task group. We're always looking for industry leaders to join the conversation and really help us drive the program forward and develop the products that we do for the sector. So I think I got us back in time, Maryland.
Well, thank you so much, Nick. And just for those who may be participating on phone, I want to just share one of the questions that came in through the chat that was answered. And then we do have a couple of additional questions. So Janice had asked, are there any known intrusions that have come in through badly configured fire servers or similar? And Daryl, I know that you had answered that. I just wondered if you wanted to share with everybody what you had said in the chat for those who are not on the platform who may be joining.
For the Hive ransomware group, their favorite targets that they look for is FortiOS, which is how they're getting into the VPN services, or misconfigured Exchange and mispatched Exchange servers. So no fire that we know of yet.
Thank you. And
No problem.
Rob had asked a question in the chat about if you have any sense of the following: the percentage of ransomware attacks that result in loss of data or loss of access compared to those where the ransom is paid. And also, is there any sense of what percentage of the attacks are actually reported? You know, OCR has issued some guidance on this, as you both mentioned, and they currently consider a ransomware attack to be a breach, of course, subject to enforcement, which could impact whether or not an entity actually reports the attack. So I wanted to see if either of you had thoughts on whether entities should be held harmless if they voluntarily report a ransomware attack. So I know those were sort of a couple combined questions. I don't know, Nick or Daryl, if you want to go first.
So an attack, I'll answer the technical part first. So the statistics that we're tracking are that a ransomware attack happens every 11 seconds. So you can kind of do the math to figure out, what percentages of companies. I've seen upwards as much as 70% of businesses have had a ransomware attack of some degree. Other statistics that we're tracking is that of all the ransomware company or all the ransomware attacks that are happening, only 65% of the victims are getting their data back. So as for what percentage that we feel is being reported, I don't know, but some of our industry partners, they are afraid that not nearly enough are being reported.
So Daryl, I just want to make sure I heard you correctly. You said that for those who have a ransomware attack, even if they pay the ransom, only 65% are getting the data back?
Yes, ma'am.
Nick, do you have any thoughts that you want to share? If not, we've got some other questions for you.
Yeah, just on the topic of OCR considering ransomware attack to be a breach and all that good stuff. Yes, HHS acknowledges that point of that, people aren't reporting because of fear of OCR enforcement, etc. Nothing to report, officially right now in terms of where OCR is going or how safe harbor laws extend or don't extend, etc., like that. But we at HHS are aware of this sentiment and the impact it's having in terms of collaboration with industry in this space, and we are exploring, routes to hopefully mitigate this or ways to improve it.
Nick, could you speak for a minute to the support that the 405D group and other industry efforts are giving for smaller entities that really don't have, a vast amount of resources for security and cybersecurity? What sorts of opportunities or documents for education or other techniques, are available for those types of entities?
Yeah, so we hear that a lot, and we're working with our task group members to really break that nut, right? Because it's hard to get to these people if they don't know what they don't know, and provide them the type of resources that really speak to them. So one of the things, concrete things that we've done is the 405D Knowledge on Demand is this training platform where we're providing free cybersecurity trainings on the 5 threats, so social engineering, ransomware, etc., as an awareness type of baseline start. So let's say a doctor's office has no idea where to turn to, doesn't know where to look. They can come to this platform and at least have their nurses, admin, or whatever, at least, take this to be cyber aware at a broad level. And the other thing that we're doing as HHS, is going out a lot more and trying to do these one-on-one engagements. We're reaching out to rural associations and networks like that those individuals and those stakeholders tend to communicate with. But, again, it's still a hard nut to crack. 405D, that is really, one of our missions is to really reach that rural stakeholder and help them. And we're only 3 years old, right? So we still have a lot of ground to make in terms of that direct connection. But I can say that we are, as a program and HHS with HC3, we are starting to see the small entities come out, right? And really look for that data, look for that help, and really speak for the voice. So I'm encouraged that there's no more kind of just head in the sand, right? It's not going to happen to me or viewpoint, that they're actively seeking this type of assistance, and our programs are boiling up to the front of that line, which is great.
Well, a lot of the work that we do at WEDI has to do with the interplay between data of different entities, whether it's the health plan, the provider, a clearinghouse. And we've been doing a lot of work lately in terms of interoperability and getting information more available for the patient as well as their treating providers. I don't know, Nick or Daryl, which of you want to take this question, but do either of you have a perspective on how this increased access for patients to their health information and this whole evolution of apps, the apps that people can go on to either track their own health status or their own, things that they may be trying to manage a chronic condition, a whole variety of apps out there tracking sleep patterns, et cetera, all of the things that impact overall health. Can either of you talk to the fact that in healthcare, whether any of these are giving you a concern regarding patient data security and, sort of how all of this increased access to patient information can really be beneficial in one arena, but in another perspective can really create a lot more vulnerabilities from a privacy, security, and cyber standpoint.
So I can throw a little bit into this. As a cybersecurity professional, I am paranoid from day one. So yes, it gives me concern, but a lot of things give me concern. That said, we at HHS are working with a number of groups to try to make sure when they develop those information sharing resources such as TEFCA, or we work on new products, new technology products that collect data, biometric data while people are sleeping or walking or breathing, to make a decision on how healthy they are. We're working with them to make sure that they keep security in mind. So we, in those applications and the data collection processes, that security is at the forefront of that. And I can speak to that because I'm directly involved with some of the organizations that are doing that and building the framework on how others should do it. Nick, you have any add?
Yeah, nothing much more than that. I was just going to highlight that our colleagues over at FDA really are leading the way in terms of medical device security. I know they have some pre-market guidance that came out that touches, I think, a little bit to what you're talking about, Marilyn, and all this good stuff coming out that's, to the betterment of us as Americans, but does open the door to Daryl's point, right? We have to be skeptical and so forth. So, yeah.
Well, and sort of a related follow-up question, how can security leaders and clinicians partner to really ensure that health information is secure without sacrificing the clinical workflow? I mean, certainly we want to be secure, but we also have jobs that we have to get done on a day-to-day basis, and those need to be efficient. And a lot of times the applications or the platforms do give us that speed and efficiency. So how do you balance that? And do you have any advice for security leaders that work in this space?
Daryl, do you want me to go? Daryl, you want to jump in?
Yes, sir. You can go.
Okay.
First.
Yeah. So one of the things that we at the 405D program, when we're, talking to organizations or to admins, nurses, or whatever, right, is just changing their mind frame that they actually do have a role to play in cybersecurity. I think a lot of nurses, a lot of doctors, a lot of they continuously think it's an IT issue, right? But they're really the first line of defense, right? They're the ones that are going to be phished. They're the ones that potentially, walk away from their computer or whatever because they're just not used to alt control delete, or they don't, whatnot. So I think it's a behavior change that we really have to start to get these stakeholders around to realize that they are the first line and they play a role. And then the second part, and something that I think 405D is through the task group and a lot of the products that we do, is that we have to make cybersecurity fit the healthcare sector, right? We have to be able to make it work in this environment, and not everything's going to work. You can't just take a computer offline all of a sudden, right? You can't just pull the plug and think it's okay. So we have to work together to figure out what mitigation steps will work or could work and be prepared on those. And I think that's a lot of the conversation that our task group is having in the development of these products is really trying to take these, baseline cybersecurity practices that for example, SISDA talks about, and apply them to cybersecurity, to the healthcare sector, and really figure out how to make them work for us instead of against us. So that's my initial reaction to that. Daryl, I don't know if you have any follow up.
No, the only thing that I've seen value for getting everyone involved is through 405D working groups or HSCC working groups. Those have been ways that I've seen, impact being made for the larger community, and plus helping us figure out how to, as IT people, sometimes we really only focus on the IT piece, or healthcare professionals only focus on the healthcare piece, figuring out how to merge the two together. through those two groups. And that's my add on it.
Carol, I want to go back to something that you talked about earlier, and this was sort of going to set us up for our next set of presenters who are going to tell us their perspectives about the lessons that can be learned from a ransomware attack.
Yes, ma'am.
But, you know, from your perspective, Daryl, do you have kind of like the top 3 things that an entity should do when they're hit with the ransomware attack? I mean, we both know that you can prepare and prepare and prepare, but when it actually happens, you have that oh no moment that you've actually got to do something. So what advice do you have for folks if they're hit with the ransomware attack? You know, sort of the first 3 things they should do.
So this is going to sound silly, but the most important advice in any incident or troubling thing in life is don't panic, right? You know, Hitchhiker's Guide was a great book, but don't panic is the very first thing. Pull out your playbook, right? So you should have a playbook on what to do during an incident. Pull that out and run it from top to bottom. And ideally, you've already built it and you've already tested it multiple times and made iterative adjustments to it for what needs to happen. And ideally, your playbook has in it, reach out to CISA, reach out to your SRMA, your Sector Risk Management Agency. In this case, it would be ASPR for HPH, and reach out to the FBI, right? That's my suggestions on the top 3 things.
Nick, do you have anything that you want to add?
Yeah, we I don't know if there's any super IT people on here, but we had a great conversation last October with the CISO from University of Vermont Medical Center on the ransomware attack that they faced and the impact that it had from a clinical care perspective. If you haven't seen that spotlight webinar, check out our website. It's on the slide deck is on there, as well as reach out to the recording. It gives a great perspective from a non-IT impact, like what it really was like to go through the ransomware. And it was the first time that I think, you know, it showed the clinical side, and there's a lot to learn from there, just about things like Daryl said, right? Like you have this checklist and you think it worked, but what didn't work, right? Vermont had a checklist, and then they went through this case study and this example and they reworked it. So it's a great starting point if you really want to see kind of intersection of where cybersecurity playbook came into place, what they thought it was going to be like versus reality from a CISO's perspective and the impact. So highly recommend that on the site if you haven't seen it.
Well, and just for transparency for everyone that's on who may not be seeing the chat, there was a question from Rob about whether HHS has considered leveraging existing communication provider channels like the popular CMS, what they call the open door forums, to reach some of the smaller folks. And I know, Daryl, you spoke to that. I don't know if you want to share your comments with everybody in terms of what HC3 is doing.
Yes, ma'am. So at HC3, that we're cyber security coordination center. So trying to make sure that everybody that has we try to make sure that all the data we can share is shared with everyone, because there was a case in a recent attack where the same ransomware group had attacked 2 other organizations that did not report that they had been attacked and didn't share those indicators of compromise. Well, if they would have shared them with us, we could have made them generic enough so that you didn't know who was attacked, and then shared them out with the larger community, right? We focus on all HPH entities, but primarily the ones that we find really need our help are the small and the mediums. So, and then we do more than just communications, though. To Robert's question, we're able to help you set up a tabletop exercise so you can test your run books. We can help you in the process of building your incident response plans or your business continuity plans and the playbooks that you need to exercise whenever you're actually going through those incidents. So
very helpful. And I just will tell you from my own personal experience, I've heard great things about both HC3 briefings as well as the 405D programs and the materials from folks who need those resources or who are looking for them. So compliments to both of you and your groups on that work, because I can tell you that in my circles and the people that I talk with, they find them both very helpful in terms of cybersecurity.
Thank
And I
you.
know this, might be out of scope. And so if it is, feel free to say that it's not really your area, but, Daryl, it really gets me that you talked about a number of these actors who can be doing the ransomware attacks and targeting and, multiple organizations from an enforcement perspective. Do you have any sense about what's being done to sort of target them and stop these actors? I know a lot of times it's difficult when they're, international bodies or state actors, but can either of you give a perspective in terms of what's being done to really get it stopping and perhaps prosecuting some of these nefarious actors?
The most challenging thing in any cybersecurity attack is attribution, right? Thankfully, ransomware actors are very noisy. They tell you exactly who they are, and they want to get your money, so they need to know who to pay. But realistically, ransomware is only a small portion, and they're probably, to me, the least scary of all of them, because they don't generally sit there for days and years, or weeks and months and years, as some other cyber threats do. So something that the community as a whole has been working on to counteract this. There's an alliance that includes companies like Google and Microsoft, on top of the CISAs and the HHSs of the government, that is working together to bring down the command and control networks that ransomware operators use, to block the websites that they're using to launch their attacks from, or to collect the command and control beacon traffic from. So that is something that we as a large community are doing. As I like to say, cyber is a team sport. So we need as many people, and we're trying to bring along as many people as we can to fight it.
Thank you. And we've got one last question. Nick, maybe we'll start with you on this. Rob is asking about smaller organizations that often rely on their electronic health record, their practice management system software vendors. Are you both working with these entities to really arm them with information to assist their customers? And can you give us any insight into what you're doing in terms of some of these platform vendors and software vendors?
Yeah, in short, yes, from two angles, really. We have some of these organizations represented on the 405B task group. So that's that collective body that is having these conversations about what this should be. But then on the flip side, because we are seeing this a lot in this, third-party vendors, whether it's for anything really, is educating the small entities on what to ask, right? Not just to say, are we doing cybersecurity, but specifically give them and arm them with the right questions to ask about, what is their posture? What are these tools? What are these mitigation practices? And what happens if you guys go down? What's the impact? And so we are working with our task group to get the right language and like content to really drill out that and give the small entities those questions, because we see that a lot, right? It's a doctor, it's a small practice, two small practice physicians. They're not IT specialists, and maybe they're outsourcing everything. Well, they may be interested in cybersecurity, but don't know where to start. So we're trying to help them get that first part. Here's what to ask. Here's the impacts, you should be worried about or should be communicating about.
Well, I want to thank both Nick and Daryl for sharing their perspectives with us. We've really put a lot of substantive information in our time together, and we certainly appreciate the information that you've shared with us today. We've come to the end of our time together for this portion of our program. Michael, do you have any thoughts or comments that you want to share before we move on?
No, Nick and Daryl, fantastic presentation. Thank you so much for being a part of the event today.
Thank you for having us and continuing to be a great partner.
Thank you.
Thank you both. Well, I think, Michael, if it's okay with you, we can move on to our next portion of the program, which is really lessons learned from a ransomware attack. And I know many are going to be anxious to hear from Stephen Leffler, who is the President and Chief Operating Officer of the University of Vermont Medical Health Network, as well as Dr. Doug Gentile, who is the Senior Vice President for Information Technology, also from the University of Vermont Medical Health Network. And I know both are going to provide their perspectives of their experience and what they went through and give us their, advice for lessons that can really be learned to help all of us. So with that, why don't I turn it over to our doctors?
Thank you, Marilyn. I'll go ahead and get us started here. So this whole thing starts, I think it was October 26, 2020, having a normal day, running the hospital as normal as any day, could be running the hospital. And late in the morning, I think it was between 10 and 11, I couldn't refresh my email, which I thought was odd, but not something to be super disturbed about. It was kind of nice. And so I went out and did some other stuff and I came back and my email still wasn't working. And then just a little bit later, I found out that our Epic system was also down. So now it's getting a little more concerning. We do have good downtime procedures for Epic, so our teams are switching to that. But then all of a sudden, more and more things started going out. Our phones weren't working. We couldn't get information from the lab to the floors. We were having some trouble with radiology and a whole bunch of areas across the hospital. And about that point, I hear from Doug and his team that we've suffered a cyber attack. I have to tell you, at that point, I still wasn't super concerned. I thought to myself, okay, that means we're not going to have the computers for maybe a couple of days. We've survived a couple Epic upgrades. We've survived turning Epic on in a couple different places. I think this was a Thursday, so gosh, by Saturday or Sunday, we'll be back on. They asked me to go on the news late in the afternoon to reassure the public that we were going to be okay, but it was out there that we had sustained some kind of attack on the system. So late in the afternoon, I go on the news reassuring the public that we do have good downtime procedures. It's going to be okay. We know how to care for people, and we are on our backup systems now. But we had already had to do some different things than usual. We had never really had our phones be down before, and our phones were connected to the computers. And so we basically sent a bunch of people over to Best Buy to buy walkie-talkies so they could communicate. And we told people to use their own cell phones within the hospital. We also reassigned a bunch of leaders to basically run labs from the lab to the floors because there was no way to communicate those labs, especially critical labs, back to the important areas. I get done with the news. We have a late afternoon meeting, and Doug tells us, Dr. Gentile tells us the really bad news that this is a cyber attack, and it's not a little thing, it's a really big deal. And I can remember it well. He says, we could be down for a month. And I was shocked. And I literally went home thinking, how can we possibly be down for a month? He basically knew at that point that the whole system had been significantly impacted. I'll just tell you from my perspective, not an IT person. So I know where I'm going to screen right now. The million people are really smart in IT. My solution to all computer problems is to turn it off and turn it back on. I don't know anything about computers at all. But our IT people did many things to protect our staff and patients. Before I even knew about it, they had turned off Epic and disconnected it from the system. They had done a bunch of other steps like that once they realized what was going on to keep us all safe. And if they had to wait to get to people like me or the network leader or someone else to do that, it's very possible that as bad as this was, it could have been 100 times worse. So I'm so grateful for they followed those procedures. They did them right. They didn't wait to get permission to do the right stuff. So that night, it was very hard to fall asleep trying to imagine what this was going to be like. I'll stop there. I'll let Doug get you up to speed to where they're at. And then we can talk about starting that Friday morning, the steps we started taking to try and figure out how we're going to get through this for an extended period of time, not a day or two.
Thanks, Steve. Okay, I'm not used to Zoom, we use Teams. Okay, I'm going to share, I have a few slides I'm going to just go through. So I'm going to try to share my screen here. People able to see that now? Steve, are you seeing it?
Yep,
Yes.
perfect.
Okay. All right, great. So, so what exactly happened? So this was October 2020. Some of you, I'm sure, remember that there was a huge REIC cyber attacks on healthcare, specifically targeted, we felt at that time, around COVID and creating extra disruption. This was not REIC. This was not targeted at us. It was not targeted at healthcare. This was a run-of-the-mill email phishing attack that we got caught up in. What actually happened was an employee was out of our network. She was visiting her family. She got an email from her daughter that was from a local business. Asked her mom, she was having trouble opening it. Her mom opened it on her corporate laptop. It was from a legitimate business, but that business had been hacked. When she opened that email, it downloaded malware to her computer. 2 days later, she comes back into Burlington. She connects to our network via a VPN, and they launched the cyber attack. So this happened, we first, as Steve said, we first got indications that there were some system problems, around 7:30 in the morning. We stopped, called an incident command. It took us about 3 hours. Early on, we started being suspicious that this was something more than just a routine system outage. By 11 o'clock that morning, we actually got confirmation that this was in fact a ransomware attack. And what we got was a file on one of our encrypted, a text file on one of our encrypted servers that said, hey, we've encrypted all your data. Here's how you contact us. So we never got a ransom note per se. There was never a dollar amount, just contact us if you want to get your data back. So what they did, so what happened, they were able to and they were pretty smart about this. They really covered their traces. So we don't have all the details on exactly how the attack went down. But they ended up getting credential privileges, gaining access to our virtual infrastructure. They encrypted the data on 1,300 servers. All of our core infrastructure was down. They also deposited malware on over 5,000 end user devices. They do this for persistence so that they have a back door to get back in and cause more harm if you don't respond to their demands. As Steve said, Epic was on a different network segment. It was not directly impacted, which was very lucky and fortunate for us. As soon as we realized what was happening, we did take Epic down completely. We couldn't run it anyways because Citrix was down, but we wanted to protect it. We wanted to make sure there was no spread of the malware to Epic. We were extremely fortunate in this incident that no data was breached, and we have forensic evidence that was the case. Went through a big OCR investigation, and they also concluded that was the case. So as bad as this was, as bad as being down for a month was, none of our data was breached. So, from my perspective, that's huge for our patients. I mean, we obviously have a fiduciary responsibility to protect that information. So we were actually kind of lucky in that regard. So immediate response. As I said, we called our standard IT incident command. We had a cybersecurity retainer, forensic retainer with Cisco Talos that we activated immediately. I would encourage any healthcare organization that does not have a retainer that this was incredibly valuable. Hopefully you never go through this. If you do, hopefully you only go through it once. You are not experts. We are not experts in how you manage a major cyber attack like this. These guys are. And say they were incredibly helpful, particularly that first week, as we were trying to chase down indicators of compromise and figure out exactly what had happened. We also, I think, as you all heard in the last session, we immediately contacted law enforcement, both local and federal. I learned that virtually every federal agency has its own cybersecurity group now. The speaker in the prior session said, call the FBI. That I would echo that. They were by far the most helpful group. They actually sent their agents and sat in our IT offices for the first 2 or 3 days of this attack. They really helped us identify who the attackers were, They were very helpful in talking through how we respond. At the end of the day, they don't want you to, pay, but at the end of the day, they were very clear it's a business decision. We'll support whatever you do. We did not. We were fortunate again that we had good backups. They never got to our backups. So one, that as the FBI was quick to point out, as you heard before, if you pay them, it doesn't guarantee you're going to get your data back. Number two, the way that this attack happened, we weren't sure even if they gave us a de-encryption key that we would be able to restore it, and we already had good backups. So we never actually contacted the attackers. As Steve said, once we realized what was happening, we shut down all our network systems, we took down Epic. We also did a perimeter lockdown. We cut off all internet access for UVM Medical Center. And we did that for two reasons. One, to prevent the bad guys from getting back in and doing more harm, but also to protect our affiliate hospitals. We didn't know what we didn't know at that point early on. We didn't want this to spread to our sister hospitals, and we didn't want it to spread to our many business partners. So we just took down our internet connectivity for a couple of days. And then we went into business continuity mode, as Steve described. So what worked? Close collaboration with law enforcement was very helpful, particularly in the first few days. As Steve alluded, as soon as I realized what was happening, I called our CEO and our chief operating officer and our chief counsel and said, look, here's what's happened. Here's what we need to do. And they said, do it. When you're in this situation, you do not have time for committee decisions. You need to make decisions quickly. You need to act quickly. And we were given the permission to do that. I assured them that if there was a major decision that was going to impact the whole organization, I would, inform them, but they basically gave us permission to move forward. We opened up the IT incident command, but concurrently, Steve and his leadership opened up a hospital incident command. We had at least one operational leader sitting on our IT incident command. We had one of our IT folks always sitting on the hospital incident command to make sure that communication was flowing both ways. That allowed IT to focus on restoring the systems. It allowed the hospital to focus on how do we continue to provide care with our EHR and other systems down. The other critical role that hospital incident command played was in prioritizing system restore. So as most organizations do, we have tiering for our systems gold. We call it gold, silver, bronze, gold being the most important, most impactful systems. But we have a lot of gold systems. We have a lot of silver systems. So within that gold category, which were the most important to restore first? Obviously, Epic was the number one priority, but closely followed by radiology. You quickly learn you can't run a hospital without imaging. But even within that, some of our gold systems might have required a silver or a bronze system to actually be fully functional. So talking through that with the clinical and operational leaders was really key for us in IT to really know what the priorities were. And so working very closely to do that. And then obviously the incident command and Steve's group had to make a lot of clinical care and service decisions with our systems down to make sure that we were still able to provide safe care. Steve will tell you that he and our informatics team spent the first few days on the floors teaching our residents and younger providers how to write paper orders because they'd never had to do it before. Steve and I have, unfortunately, were around long before EHR, so we knew what it was like, but a lot of our newer docs had never done it before. So we actually had to teach them how to do that. Challenges, downtime procedures. At that time, Epic recommended only 3 days of data in your Epic downtime computers. We were down for a month. So after 3 days, we didn't have clinic schedules. So clinics had no idea who was coming in for visits. So one of the first things that we had to do was get secure access into Epic so we could actually print out clinic schedules and distribute those out to all the clinics. So they at least knew what patients were coming in. We do have good downtime procedures, but no matter how much you focus on this and emphasize it, staff are rusty. You know, it's just not the priority for busy clinical departments to practice these routines. Communication, Steve talked about the phones being down. We focused a lot on bringing your own device the first few days, and then on internal and external communication workflows. So we have IT is in a separate building here at UVMHN. We had our chief operating officer, our head of marketing and communications, our chief counsel sitting in the offices next to mine, so that we could make quick decisions, but so that we could also, so that we weren't having to do extra work communicating, passing on information to our communication folks. They were part of the daily discussions. So they were in the loop in terms of what needed to be communicated both internally and externally. Another big problem, like most organizations, we'd spent a decade trying to get rid of paper. Suddenly we had paper everywhere. I remember walking into the lab on like the second or third day, and they had a conference room that they cleared out, and they literally had stacks of paper all over the floor. So we quickly had to figure out how are we going to process and manage all of this paper. We brought in, so we actually furloughed people who didn't have work because so many of our services were shut down. We brought those people in and paid them to actually process the paper and file it, and make sure that we had it available. This was COVID, so we were also dealing with the fact that our big part of our workforce and almost our entire IT workforce was now remote. So we had to do all this working through with a newly remote workforce, which was interesting. That's sort of, I think, common these days, but at that time, that was a pretty big challenge. And then just the daily clinical service and patient safety decisions that Steve and team had to make. So sort of key learnings, cybersecurity, it has to be a top organizational priority. Like many organizations, I was new, and I think I was 4 or 5 months into this role when this cyber attack happened. But we had cybersecurity on our investment and budgeting list for 3 or 4 years in a row. And it always got sort of pushed back because of clinical and operational priorities. You learn when you go down that those aren't priorities if you don't have your systems up and running. Ensure your downtime procedures. So Epic actually changed its recommendation based on our experience and that of some other customers. They now suggest a month's worth of data in your backup systems, for example. I think the thing that worked best for us, honestly, was that the entire organization was focused on this single thing. So it was really close collaboration between hospital, clinical and operational leadership and IT that really allowed us to get through this and to get, within a month we had, you think about it, 1,300 servers, 5,000 end user devices that have to all be restored. We had to completely wipe all those user devices and re-image them. We couldn't have done it without the close cooperation and the close collaboration with the clinical and operational folks. Cyber insurance, if any of you have had to go out and get cyber insurance lately, it's really expensive if you can even get it at all. So that's another thing that, you need to take into account here. I think that's it. So Steve, if you have other things you want to talk about.
Yeah, I just want to add on to a couple of key things from Doug. So we did not, when we started this process, have incident command separated into 2 parts. But I think it was either Friday morning or Saturday morning, Doug and I got together afterwards and said, look, there's too many people in this meeting and we're not getting through all the important stuff. So initially, incident command was really focused on the IT component. And there was all these clinical questions we couldn't quite get answered. And so then the clinical people were having a side meeting, but we didn't have IT there. So I think it was by Sunday or Monday, we stacked them. So IT went first. I always made sure a clinical person attended that meeting and kept the key takeaways. And then we went right after them. But then almost always Doug came or his second in command or someone very senior, and they would hear what was going on. And literally like on Monday or Tuesday, they're like, okay, what do you want us to focus on? We wanted schedules. Like on Monday, we no longer had schedules for the clinic. People were showing up. No one knew why they were there, what their complaint was, anything like that. So we focused on that. When they got us that, they'd come back and say, okay, what do you want next? And we literally would have a conversation in there. The second thing that was very difficult, but I'm very proud of now, is that we're the tertiary care hospital for the state of Vermont. We provide high-end care that you can only get here. And our tertiary care partners that are within 90 miles of us, Dartmouth, Bay State, Albany, they wanted to help, but they were very busy. They were full. They could not take all of our patients. Going on divert for 3 or 4 weeks was not an option for Vermonters who needed us. We knew we were going to have to deliver babies. We knew we were going to have to take care of sick traumas, do some heart surgery. And so on Friday, we stood up a clinical leaders meeting where our chair of surgery, anesthesia, the ICUs, emergency medicine, pediatrics got together, and they determined what cases we needed to do and could do every day. And over that month, we did many heart surgeries. We did many cancer staging procedures. We took care of a lot of traumas. We delivered hundreds of babies. And I can say I'm very confident at this point, without any harm to patients. We did it on paper. And Doug is right. That Friday morning, I was walking around the floors and we had many, many residents who had never written a paper order, never written a paper discharge. And we were teaching them on the floor in real time how to write admission orders. Doug mentioned this. Our lab had thousands of pieces of paper on his conference floor. And early on, we had our medical students come over from medical school and start building files. And they had a color coding system. So a red lab that came into that office was run to the floors, and we got better. And I will say one semi-sad thing is about 3 weeks in, if you walked the floors, it was like the old days where the teams would be rounding and they'd all be together and the nurse would be with them, because we rely so much on Epic now to communicate with each other. I can send Doug a quick side message that seeing the old day rounds actually was really good. I was hoping that would stick, that connectiveness, but we've kind of reverted back now to Epic. It's just so efficient to just send someone a side message. IT is a huge part of it. The other thing I'll tell you, as someone who was not an IT person, before this happened, when Doug or his team would come forward and ask for millions of dollars for security measures, I always thought, man, we just don't have that money, can't do it. I listen very carefully now. I'm super thoughtful about when they say this is a risk to us. I'll just add this, it's embarrassing, I'm going to tell you. So we send around emails now to try and bait people into seeing if they can make you give your credentials. And I've been doing really well. And about 3 weeks ago, I was having a super, super busy Friday. I had 5 things going on, and it was November, and I knew that it was getting time to renew for my insurance from the hospital. And I had 10 things on that morning. It was not a great day. I got this email. They were asking for my credentials for to renew my insurance, my health insurance plan from the hospital. And I looked at it. It looked a little funny. I went over into the right spot. I went over into the thing that I knew was the right way to do it. There was nothing on there. And I thought, that's really weird. And so I went back and clicked it and got the email saying, you know, you would have given your information. I had to take the ongoing training. I'm the leader of the hospital. I lived through 30 days of this pain, and I could have made a mistake. So we have to have systems to keep us safe. I thought it would never happen to me, and I was a stressed morning, and it happened in 5 minutes, even though some red flags went off. I just wasn't focused enough on it. So you have to have a backup system to protect your staff from the inevitable. I think it's, we have, 8,500 employees just at the medical center. It's going to happen. So I'll stop there. We're happy to answer questions.
Yeah,
Steve and Doug, I really want to thank you for your candor. This has been a very interesting session to hear, your personal experiences and perspectives, and, certainly appreciate your honesty. I think, Steve, you were the one to talk about sort of the public outreach and what you did with the community. Can you tell us a little bit more about, who you reached out to? How did you reassure them? Did you have a crisis communication team, that sort of thing? And how did the community respond? Were patients who were in the hospital worried? Were you starting to get then an influx of calls? Give us a little bit more on that.
Well, early on, we couldn't get any phone calls. So there was not a lot of calls coming in. We did have a crisis communication team. I will tell you, it was extremely challenging to deliver the message because both Doug and I are ER docs. We've been ER docs for a long time. It's hard to rattle us. I didn't want to scare the community. I wanted to make sure they knew that if they did have to come for emergent care or to deliver an expected baby or had scheduled cancer care or whatever, that they could count on us. But I also wanted to make sure they knew that things weren't normal. And so on the first day I went on the news, I at that point gave the information I had that we didn't know how long it'd be down for. And then starting on about Monday, I was on the news almost every day, it seemed like. And it's interesting, I was trying to give clinical updates. Like on Monday, I would say, we're having trouble knowing your schedule. If you're going to the office, and we got the phones back up, I think it was Monday or Tuesday, the phones came back up. I said, call ahead of time. Tell them you think you have an appointment and what time you're coming so we can be ready for you. Like I would say that on the news. I would reassure people, our emergency department's open. We are, if you've not heard from us, assume that your care is going to happen here. We did, so we had a huge issue with oncology care. We didn't have people's protocols. We didn't know how far into their chemo they'd been. For some people, it had gotten worked up because after 3 days, we didn't have that. But we worked with Dartmouth and Albany. We did send a number of our cancer patients early on to Dartmouth to get their chemo because it was hard. We couldn't deliver it all here. We had to slow way down because it was all on paper. We had a pharmacist down there for every dose to make sure it was safe. What the news really cared about, all they cared about was if it was a ransom attack and how much we had to pay. They really didn't care that much about the clinical stuff. And Doug will tell you that they got so frustrated with me every single day on the news. The number one question I got was this ransom attack? And early on, the FBI told us it'd be better not to let that information out. So I had to keep saying no, or not to my knowledge, and then when it was appropriate, we did say it was a ransom attack, and they wanted to know how much. I mean, literally for months after the attack, people wanted, that's what they really cared about. But we did, so every news time I went on, I made sure to talk about some of the clinical issues we were facing and tried to reassure people. The flip side is you get back to the hospital and the doctors would say, man, don't reassure people, it's bad here. So there was this weird balance I was trying to do. But what the media wants to know is it ransom? How much are you going to pay, or are you going to pay?
Well, and Doug, we've had a question. You talked about the volumes and volumes of paper. And so while you were in it, that's sort of what you had to do with. In the old days, we always talked about dropping a paper. What did you do afterwards? You know, once you had all of this paper and you had everything back up and running, can you talk a little bit about the process? I mean, were you scanning? People were manual entering? What did you do to get that information into the records?
Yeah, it's a great question. So the long pole in the tent here was backfilling that information so we could bill for services. And it was a challenge in multiple ways. One, just getting the information into Epic so that we could bill it. And we did scan notes. We didn't ask providers to go back and enter orders or scan notes or enter notes into Epic directly. We scanned that information in. But just getting sort of basic, we did actually have teams that actually went in and entered some of the procedures and supplies and things like that were billable so that we could bill for that. A lot of times, you know, one of the challenges you have when you move to paper in the situation is people don't do sufficient documentation. So we ended up writing off quite a bit because even though we had some documentation, we didn't have sufficient documentation to be able to bill for it. But that was, I don't know, Steve, that was probably a year almost before we, you know, really got all that done. That was really the long pole in the tent, was getting all that information back in. And it was both, it wasn't just for billing, by the way. We also wanted that information for clinical reasons, right? So we did want people to go in and update problem lists and med lists and allergy lists. So that is one thing we did ask our clinicians to do once we got our systems back up.
And we're lucky that our clinical informaticists, there's a bunch of physicians on that group. So they made decisions about what needs to be in the record in a way that automatically pops up. Think labs, think radiology, things that you're not going to go through a bunch of scans to find, right, and what is more reasonable to have it be scanned. So it took a year, but basically I would say all critical information got put in the location where you'd expect to find it, so that if you went back to November of 2020 now, and somebody had a creatinine, it's in the split place you'd be looking for it normally. You wouldn't have to go through scan documents to find things like that.
That's helpful. Well, Tina Grande, who is my co-chair of the WEDI Privacy and Security Work Group, is with us. And I know, Tina, you've got a couple of questions that you wanted to ask. And so why don't I turn it to you and you can kind of take it from here. Well, Tina's having a little bit of a technical issue. Just let me ask the question that she had.
I made it, Marilyn. Sorry
Here
about
she
that.
is.
I think there was just a lag in turning on my mute and video capabilities. Thanks, Marilyn, and great to hear from you, Steve and Doug. What a fascinating and troubling experience you went through. But Shane, thank you so much for sharing all the information. I was really curious, working here in Washington, we hear so much about all the different agencies that are working on cybersecurity reporting requirements. And you had mentioned that you reached out to the FBI initially and that they were really helpful. How did that whole reporting process work for you? Did you find that you had multiple places or agencies that you needed to report to? Were there state requirements that you had to abide by? And was it confusing? And do you have any advice in terms of streamlining reporting requirements or anything, at that level that you'd like to share with the group?
It was confusing the first couple of days because we weren't sure which agency to report to. As I said, almost every agency now has its own cybersecurity group. The FBI was incredibly helpful, and not just in us dealing with the cyber attack, but in helping us sort through that. And at the end of the day, and I think again in the prior presentation he mentioned this, that's who I would call from a federal level. In terms of state, we are in contact with the state security and regulatory bodies from the very beginning. There wasn't a lot of state reporting that we had to do. It was more just keeping communication open. Obviously, as Steve said, we are the tertiary care hospital for all of Vermont. So the state had a big stake in this. They actually Governor Scott mobilized the National Guard. So they have a cybersecurity group at the National Guard. Many of our security folks who work for us here at the hospital were friends with those guys because it's a fairly tight community here. So we actually had a number of them come and help us in that first week or two, just as extra hands as we worked through some of this stuff. So that open communication with the state was very helpful. In terms of reporting, I don't recall that there was any major challenges at the state or federal level once we sort of sorted out who we needed to be working with.
That's good. That's really helpful. There's a lot of focus on that here in Washington about which agency is in charge. Is there one point of contact? There are so many cybersecurity bills floating around Capitol Hill, and so much of it does focus on the reporting requirements. So it's interesting to hear that it wasn't quite as complicated for you all as sometimes we here in Washington, assume it might be.
Well, again, it was very confusing initially, but once we and honestly, the only group that was helpful was the FBI.
Wow.
So once we realized that, we just said, okay, this is who we're working with. And, but it was pretty confusing the first couple of days.
Did you work with CISA at all?
We did. At least in our situation, they didn't really have much to offer, to be honest with you.
Oh.
So.
Well, and it seems like, Gina, one of the lessons to be learned then is it helps to have one point of contact for dealing with, for example, the federal government.
Right.
Maybe that's one of the best lessons.
I hope I didn't offend anybody with that, but for us, it was the FBI who was really, they literally were in our offices with that next day. So they were extremely helpful.
That's great.
Steve, we've got a question in the chat from Rob, and he's asking whether you had any issues with connected medical devices going down, for example, in your ICU. I know from my own experience, sometimes the devices can function independently, but some of them are tied into a system. And so can you give us your perspective on some of that from a clinical perspective?
I believe all the monitors and everything worked, Doug. I don't remember that being an issue. So of all the things that we had, thank God, all of our monitors and so on worked.
Yeah,
And we stopped.
our alarms were all still functioning.
And we've also got a question, to the extent you're comfortable addressing it, which has to do with your cyber insurance policy. You know, do you have any sense about what it covered and what it didn't cover? For example, did it cover the, costs of walkie-talkies? Did it cover the paper? Did it cover,
So, yeah, I'll
vendor
start.
expenses?
So here's the good news. We had 30 million of coverage. Here's the bad news. We had about $65 million of losses. A lot of it was care write-offs, loss of volume, sending cases away. So we pretty easily got up to 30 million in claims. I'm sure if it was close, we would have had to fight over walkie-talkies or something like that, but it wasn't even close. We had so blown through how much coverage that we had that it really wasn't an issue. We were easily able to show losses well beyond 30 million that weren't really even debatable.
Yeah, we were covered for lost revenue.
Yeah.
Just the lost revenue hit our 30 million. So we didn't get into niggling about, this or that. So,
I mean, they early on in the first couple of days, they said, well, maybe all is going to come back. Maybe everyone's just going to delay care and you're going to make it all up. But it was very clear by the end of the month that it had had a major impact on revenue, even beyond the 1 month. I mean, one of the other big issues that people shouldn't underestimate is we got Epic back up in a month and we were so grateful and so thankful. Radiology was still another 3 or 4 weeks. Radiology had major impact. It was still, I think it was about 3 more weeks, Doug, before they really came back online.
Yeah.
4. Yeah. So 2 full months for radiology. And you can't imagine the impact of that until you're in it. You think, well, God, this is over. Epic's back up. But there were still many, many daily challenges with trying to get people the images they need, look at images that either have been done during the cyber attack or before. There was a lot of other challenges there that lasted through almost all December.
Well, and to the extent that you're comfortable talking about it, did the cyber insurance cover some or all of the ransom payment? And if you're comfortable talking about it, can you share with us the perspectives of whether or not you should pay the ransom?
We didn't make a ransom payment.
You did not.
We did not make one. What I would say is we had conversations in those first couple of days. I mean, I think it matters a lot if your patient information is compromised or not. Very early in the attack, Doug's team was relatively confident, or as confident as they could be, that our patient care information was protected. They had turned it off quick enough. They hadn't gotten in. The second major thing we're worried about is staff. We have a lot of staff, 8,000 people. Was their information compromised? And they also thought that was very unlikely, is the way they were telling us, to be compromised. I think in a situation where patient care information could be compromised, it might make sense to make a different decision, but we never even really entertained it. It never really was a real conversation with us that we would do it or not do it. But I can imagine other scenarios where it might be worth really carefully thinking through.
we also knew that we had good backups for virtually all of our servers. So for us, we never even contacted the attackers. We just said, we're not going there. We don't need it. Probably not going to help us even if we do. So we were lucky there. If we hadn't had good backups, it would have been a very different conversation.
So Tina, it sounds like one of the other lessons to be learned is that you can survive an attack without paying the ransom. I
Yeah,
know a lot of people feel like they have to.
exactly. And out of curiosity, I mean, did you ever find out who the attacker was?
So we, working with the FBI and looking at the indicators of compromise, we have a pretty good idea. It's a well-known group that's Eastern European.
Okay.
That's about all you know, right?
Yeah. So it was a nation state thing and you knew it wasn't.
Well, we don't know if it was nation state necessarily. They certainly operate out of, typically out of Eastern Europe, but
Yeah.
it's one of those, I mean, the one thing that I don't think people really understand about ransomware today, it is a professional business and it is run like a business. They actually have groups that do, each individual part of the ransomware, and they collaborate. I mean, it is very sophisticated. So you don't know, I mean, you can, by indicators of compromise, you can have a pretty good idea of which group it was, but identifying the individuals and trying to bring them to justice is just unfortunately not generally possible.
Interesting.
So one of the things, again, we were lucky that they didn't get to our backups because we still had them on premise at that point. So one of the things that we've done a lot of things in terms of cybersecurity, but one of the big lessons was having those backups is, to your point, critical in not having to pay that ransom and being able to recover. So we now have backups offsite in a very secure area with another company that's what they do. And so I think really looking at your backups and making sure you've got them as secure as possible is a really important preventive if you do get attacked, if you do get compromised, so that you don't have to pay that ransom.
And we've got one additional question from Rob, and he's asking about, moving forward, the emphasis that you've placed in terms of cybersecurity on staff agreements, training, etc. How have you really emphasized the importance of what Rob's calling the not clicking? But you talked a lot about, the test run that you put out for staff to sort of keep them vigilant and aware. Can you talk a little bit more about what you're doing, moving forward from this?
So we built a mandatory, and we require all employees to take the mandatory yearly. And I think that helps. And there's a lot of key things there it makes you look at. But the issue is everyone's very busy in healthcare, and a lot of people might have their email up and be doing something else on the side. And it's just easy to be kind of, on autopilot, and the things happen. And so what I can tell you is, I think our IT team has shifted, and I've heard him say stuff like this, is look, it's inevitable, it's going to happen at some point. We have to do as many things as we can to keep the attack as small as possible. And they're using terms like, segmenting out the system now and doing a bunch of different stuff to minimize how it happens. We have focused on not blaming people for making mistakes. There's ways people could do this and compromise this, but we've made it much harder. The other thing I will tell people, I think, is an issue that impacted us, and the timing of this is, we at Vermont, we're about 6 months into the cyber attack, and we had a lot of people working from home, and we were trying to make it easy to work from home, easy to sign on the computer, easy to get through the interfaces. We had probably gone a little too far on that side. And at the completion of the cyber attack, we obviously still have a lot of people working at home, but we've really changed how they can use computers at home, how they get in the system, how they would plug back in when they get back here. We had some deficiencies there that we were focused on COVID, not so much on IT security. And I don't think that's going to happen to us again.
That's really a great perspective. Yeah, I think we sort of take for granted now the fact that we work from home, but to the extent that it impacted the ransom attack, that certainly is a good thing to add. Doug, did you have anything else you wanted to share? I'm sorry, Steve, did you have something else to add?
What I was going to say is just, Doug, I mean, if you think about, March, April, May, June of COVID, we were trying to tell you, hey, make it easy for people to bring their computers home, make it easy to get on, make it easier to do their work. I'm not saying that totally led to this, but I think it was certainly a piece of when and how it happened.
Yeah, so I'll just reemphasize two things that Steve said. So we know the employee who got the phishing attack. No, there was never any discussion about discipline for this person, because honestly, it was a mistake I could have made, anybody in this organization could make. And you can imagine she felt horrible. She was in my office in tears. And so it was really about learning. It's just like we do with quality in the healthcare. It's the same thing. You focus on the systems. People, we're human, we will make mistakes. And so as Steve said, it's critical that we have as many systems in place. At that time, we did not have software on corporate laptops that today you could not open a personal email on a corporate laptop. We've blocked that. We've also really tightened up our VPN, as Steve said, as a result of this. So having those systems in to protect us as much as possible, understanding that people will make mistakes. Steve just admitted that he made one. But any of us, I mean, I literally, when I heard about it, I said, geez, that could have been me for sure.
And Steve, if it's any consolation, I had a very similar experience at work. I'm the cyber person, and we had someone who was having a baby shower, and we had a package delivered to the office. This was again, pre-COVID. And they had sent this thing out saying that your package had not been delivered. And I thought, oh gosh, the baby shower's today, where's the package? And I clicked on it, and sure enough, I had to go for additional training. So you're not alone in that. Well, I know that both of you are part of our next panel. So Tina and Michael, if it's okay, I think maybe what we should do is move into our panel discussion and talk a bit about, sort of wrapping up for our time together, the next things that we wanted to explore, which were ways to strengthen cybersecurity in healthcare. So we've met Steve and Doug. Let me also introduce Denise Anderson, who I've worked with at the HISAC, the Health Information Sharing and Analysis Center. Denise Anderson is the president and CEO of the HISAC. We are also going to be joined by Chris Ladico. Chris, I hope I've pronounced your last name correctly. He is the senior director of Blue Cross and Blue Shield of Illinois, and he's going to be sharing his perspectives with us today. So welcome to the panel, and thank you all for joining us for this next part of the presentation.
Hello, everyone. Nice to meet you all.
Marilyn, you have the talking points for the first question. Okay, let me actually try to bring them up while I think
Yeah, I think
Marilyn's looking for them.
right. We're looking for them, but I can open here for the group. I mean, it sounds like this is sort of a lessons learned panel and what the healthcare industry needs to think about as they're implementing plans and procedures for cyber attacks. Michael, I'm assuming we want each of our panelists to talk about lessons learned at a high level, and then we can do some directing of questions. Is that correct?
That'd be great, just to get their perspective overall, kind of the
Outline, yep.
state of health. I mean, Steve and Doug did a fantastic job, so maybe we can look for Chris and Denise to open up with their thoughts on kind of the state of cybersecurity right now in healthcare. Chris, we could start with you. Welcome.
Sure. Thank you. And I have to introduce myself real quick. Chris Lodico, Senior Director, Information Security, Blue Cross Blue Shield, Illinois, which is also a healthcare service corporation. My CISO, Ian Schneller, sends his regards. He was not able to make it, so I was voluntold recently that I would have the opportunity to speak with you all today. So I appreciate the opportunity. And just to quickly talk about HSC, is that we are comprised of 5 different state plans. We are Illinois, New Mexico, Texas, Oklahoma, and Montana. We've got 17 million members, 20,000 plus employees. And we are the second largest blues in the system, right? So there's like 32, 36 different blues. We're number 2. Anyway, with that being said, we've got a lot of patient information, a lot of HIPAA records and PHI around our environment. And it's obviously our duty and responsibility to protect that at all times. We have seen an increased interest, knowledge, involvement, and awareness from our board, as well as the C-suite within our industry. What's nice about that is they see the news, so it reinforces our messages. And it's a continuous conversation of information security, educating them. making sure they understand the risks, because it's one thing to have a conversation on information security and its impacts from an operational perspective, but that gets lost in translation. So what we need to do moving forward is translate that into business speak, business risk that the business can identify with, understand, tie it back to their business processes, and build that partnership, that understanding, which would hopefully lead to funding and better security practices.
That sounds great. Thanks, Chris. And Denise, I'm jealous of your background. It looks nice and warm back there. Let me know your thoughts overall, and then I'll go into an interesting question regarding recent congressional testimony that you had. But your thoughts right now as we're closing 2022, the state of healthcare and cybersecurity.
Sure. So I'll also introduce myself. I'm Denise Anderson. I'm president and CEO of the Health ISAC, which we are a trust community within the healthcare space for sharing and protecting mitigation strategies around cyber and physical attacks against healthcare. So a couple of things. One is I thought it might be interesting to share that we did a survey in November of 2021, and we're doing it again this year, where we surveyed our members and other cyber and non-cyber executives across all types of healthcare and organizational sizes. And their top 5 concerns were ransomware deployment, phishing, spear phishing attacks, third-party partner breach, data breach, and insider threat. So I think that that's relevant and that is their concern going forward. I don't know that that's going to change much, but that is some of the things that they're concerned about. I think just in general, some of the things to think about are that the threats are not going to go away. They're going to evolve. The threat actors, as Steve and Doug have alluded to, are a business, and so they're going to continue to evolve in ways that they can get what they want, whatever that motivation is, depending on the threat actor group. I think we also need to be taking a enterprise risk management approach, so looking at the whole enterprise and all the threats, knowing your assets, knowing what can be impacted, knowing the impacts of being down for a long period of time, and then protecting your organization against with that strategy in mind. The weakest link, of course, you've heard today that people in this case were the weakest link, but the threat actors are going to go after that, whether it's your supply chain, anyone that you're working with in your ecosystem, and or your people. You heard Steve and Doug talk about operational resilience, and I think that's really important. It was really interesting for me to hear where they split the teams up between the IT team and the clinical side. This was something we actually, when I was in finance, found during their attacks of 2012, 2013, where it was absolutely imperative that they limit the decision makers to 1 or 2 key people and then split the teams to one that's IT incident focused and one that was focused around everything else. So I found that very interesting, and I do think that that's very important to have an incident response plan and then to exercise that plan and communicate that plan so that everyone's aware of it. And finally, just wearing my ISAC hat on is the fact that you're not alone. When something like this happens, there are communities out there that can help you, whether it's law enforcement and or ISACs and or other peers, that this is not something that we have to do alone. And the criminals don't do it. They partner when they need to, so we need to make sure that we partner with everyone on our end to make sure that everyone is in the best possible situation that it can be.
Sounds fantastic. Marilyn, I'd like to hand it off to you for maybe our first discussion question.
Okay, thanks, Michael. Denise, you had talked earlier this year, I think it was, about cybersecurity experts when you testified in Congress. And you really focused on the need for training and advocacy. And the committee, which you're welcome to share with the group, the committee cited 4 items as risks to overall cybersecurity within healthcare. And they talked about the lack of skilled cyber staff, the lack of cybersecurity situational awareness, lack of knowledge and training for medical staff, as well as what they call the C-suite, the CEO and the board level folks. And they also talked about a lack of cybersecurity strategy from a risk management perspective. That was several months ago from what I remember. Have you seen any movement on those 4 fronts? And after Denise is done, we'll open it up to the rest of our panelists to see if they have any thoughts about that assessment.
Absolutely. I think that we have made some progress in that area. One, the Sector Coordinating Council, so the Health Sector Coordinating Council Cyber Working Group, has been very active in helping develop a workforce. So making sure that there is some training that we can do, and they've actually come out with a series of videos that are going to be very useful. From what the first one is about to be produced is for the clinicians, so that they understand the role of cyber that cyber plays in their environment. So there is some definite good work being done in that space, and I would encourage you to go to the Sector Coordinating Council's website. If you're not aware of it, I'm sure we could share it, and they have a lot of great, useful materials there for people that aren't necessarily tied to IT, right? So these would be like your clinicians or nurses or anybody else in the healthcare space. As far as enterprise risk management, I think more people are starting to jump on board with that and understand that we need to be focused on risks to the organization. And situational awareness is also huge in that, plays a huge role in that, because you're understanding not only all the implications of everything, but the implications to your organization and how long you could live with that situation. So, for example, even thinking about things, it doesn't necessarily have to be cyber. Things like climate change. For example, in the UK this summer, they had a huge heat situation where data centers were closed. So think of the impacts that can have to your IT and operational infrastructure, and that has nothing to do with an IT attack. So understanding all of the potential things that are out there that could affect your organizational operational resilience is very important. And I think the more we can beat that, there's a lot starting to come out around that to get people to think that way. I think the better off everyone will be. I don't know if I touched on everything there, but those were a couple of the key ones that stood on my mind.
No, I think that's helpful. Before we move to the next question, do any of our panelists have anything else to add?
Yeah, first of all, I think that was a great answer, Denise. What I would say is that what I've realized since our attack is that there is heightened awareness of leaders now. So prior to the attack, there was a lot of talk about devices, and we would constantly be asking IT to help make us more connections and make things easier. And I was probably even one of the people advocating with Doug, like, let's make the connection here. And he'd say, no, the way that the software structure for that doesn't meet our security needs. That pretty much shuts it down now. No one tries to push on those. We've had to figure that out. We spent a lot more time on education, but we realize education is never going to be enough. No matter how much we educate people, in a busy moment, someone's likely to click and open something. And so infrastructure has to be able to minimize the damage that occurs. And so I really pay attention now when Doug's talking about the 5 steps they've taken so that when the next attack happens, it won't be 30 days, right? That I just think it's inevitable. These people are out there, no matter how good a job we train everybody, there's 8,000 people here. Someone's going to make a mistake. It might even be the president of the hospital. Someone's going to click into something they shouldn't have with the best of intentions, or they're going to figure out some other way in. So how can we make sure that our system, getting our backups off site and in as secure a location as possible, that's a big step, right? That probably prevents you from paying ransom. How can you, and I'm going to use, I don't know any of these terms, but Doug, we've segmented our system now into a lot of little pieces. So if they got into one part, it's unlikely they get everywhere again. That to me feels like really important work. And that's from a non-IT guy.
Yeah, I think Denise said this well. This is an arms race. They are very well funded and they are very aggressive. And, we just have to try to stay one step ahead, which is not always possible. And so, and just as Steve said, we've got 14,000 employees. Somebody's going to make a mistake at some point. And so limiting, you have to assume they're going to get through at some point. And so limiting the damage they can do if they do get through and detecting it as quickly as possible really becomes essential.
And I think that's a nice segue into our next question, which is that it really appears from the outside, at least looking in, that there are going to continue to be these kinds of what we call evergreen issues in healthcare cybersecurity. And so where do each of you see the roadblocks as getting to significant security advancements? I mean, a lot of this is tied into budgets and resources, but also understanding, training, et cetera. So maybe if we could just sort of do a round robin, where do each of you see the roadblocks to getting to significant security advancements?
You know, one of our big challenges, and it's, I see it in a question further down, is that we have hundreds of vendors for lab equipment, for radiology equipment, for applications that our users want. And the cyber in general, they have not taken cybersecurity nearly as seriously as they need to. We are constantly faced with choices, clinical business choices of, do we take this sort of unique application or piece of equipment that has high clinical value but doesn't meet our security requirements? And you know, sometimes we just have to do it because there's no other alternative, and we try to microsegment and keep that equipment as segmented as possible, but it still opens up vulnerabilities and broadens our vulnerability footprint. So, you know, I think national attention at that, really pressure on these vendors. A lot of them claim, well, it's the FDA, you know, I have to go through the FDA process all over again to get my, you know, application or device certified. And the government has said, no, that's not the case, but that's still often the excuse that we hear for why they're lagging. So any pressure, and you know, as an individual organization, we have limited power there. So I think the more we can do on a national level to really heighten the security awareness of all of the healthcare suppliers is really important.
Chris, do you want to go next?
Sure, and great answers, by the way. And from my perspective, you know, it's always a contention. We always have to figure out how can we support the business, how can we enable the business, given their business innovation, all their imperatives. But we know that we've got constraints, financial constraints, resource constraints, et cetera. So how do we position ourselves to enable them to help them build securely, to help them deliver securely, right? So different ways we need to think outside the box. So resources, right? Finding that perfect individual, that unicorn, it's unlikely, right? We don't have the time, it might not exist. So what can we do to mitigate that, right? Let's cross-train. Let's take people from different areas and bring them in your organization so we can train them up and we can get them evaluate their new perspective that they bring to the table, right? Finding ways to partner with the business, right? Make sure they understand the risks of their decisions, right? Understand how their business imperative is going to change the way technology has been implemented, right? Making sure that they understand, hey, if you want to do business with this third party, we don't like these factors, right? This is the risk. We need to make sure we're aware of it. And we've got mitigating controls in place in case something bad were to happen.
Steve, do you have any thoughts on this?
Dave covered it. I'm good. Thank you.
Denise?
So I do think a lot of times it's not necessarily the technical piece, it's more the people and process. And I think if I could point to anything, people are probably one of the biggest constraints or roadblocks for a variety of reasons. And I'll just pick something really simple like information sharing. There are a lot of reasons why people don't share information, but it's not necessarily the reasons that you would think. And some of them are, for example, just the fact that they think that the group that they're sharing with might think that the information they're sharing is not that relevant, that there are bigger guys and have bigger, more important things, and we'll look down on them because they just shared some piece of information that was probably not as important as others. So I think, you know, the more we could change our mindset to really put the emphasis on security and operational resilience and making sure that we communicate and work together as a team, because we all are connected, right? It's one big ecosystem. The other thing I just want to push out there, because I don't think we think about it enough, and that is concentration risk, so concentration of vendors. So we all rely on the Microsofts of the world or the Epics of the world. One of the things that came out during the pandemic was there was a pharmaceutical manufacturer of containers. So they produce containers for pharmaceutical and therapeutic products like vials or actually it was cardboard packaging, to be honest with you. And they were taken down by a ransomware attack. What everyone didn't realize was that they all used the same vendor. So it had big implications for many of these pharmaceutical manufacturers as they were trying to get out COVID-19 vaccines and therapeutics. So the more we can communicate with each other and be more aware of the risk to our organizations and to healthcare writ large, the better off everyone will be.
Well, Chris, as a representative for the payer community myself, I'm going to direct the next question to you. And I think it's, one that's important from a payer perspective, but, since you represent a payer organization, are there special considerations that you have to undertake that might be different from your counterparts on the panel today who really focus more in terms of the provider perspective?
Sure. So I guess being a payer, obviously we receive a lot of money from our members and from our groups and so forth that we do business with. And at the same time, we wind up paying out the providers as well. So we kind of function in essence like a bank, transferring money in and out. And so we're seeing that, our business is revolving around tremendous dollar amounts that really enable services to be performed, and therefore protection of that supply chain is critical, of our vendors, et cetera. And it could be that we are facing more of a hardening of our healthcare, right? More stringent guidelines taken from the financial sector and applied to healthcare. So we constantly are looking at different regulations, different requirements out there in the industry, and comparing and contrasting to our financial counterparts, strengthening where we can, identifying gaps and risks, and just continuously evolving our security capabilities and program to fall in line eventually with the financial services industry.
So Denise, I know you touched upon this with respect to the third-party vendors and, what we commonly call the business associates that are targets for cyber attacks, ransomware attacks, et cetera. Denise, can you address how payers and providers may be able to better coordinate so that they can all ensure that their data and systems are safe? I think particularly as we start to move more towards the TEFCA and interoperability of records, this is going to continue to be something that we all need to keep top of mind.
So I think that there's a number of ways that we can do that. One is participating in the Sector Coordinating Council. There are a number of working groups there that are concentrated on various topics that are relevant to healthcare security. So that's definitely one that area that people can collaborate on. We also do the same thing within the ISAC. We're a little bit more focused on operational as compared to the Sector Coordinating Council, which tends to be more regulatory guidance perspective. But these working groups are very valuable. I think just in having those conversations and not operating in silos, people open up their minds to the problems that exist out there. One of the things that we did one of the things I did when I came over to healthcare was I was a little astounded by the fact that there was a lot of finger pointing between the medical device manufacturers and the providers. And there's still some of that going on, but we've come a long way. And one of the things that we did at Health ISAC is we created the Medical Device Information Sharing Council, where we have two co-chairs. One is a provider, one is a medical device manufacturer. And that group has really had solid conversations around the issues that confront both perspectives, that of the manufacturer as well as the provider. And they're working together to solve problems. And I think that's what, when I alluded to earlier about the will, I think it's the will for us to come together and realize we have issues within healthcare, and we need to work on them together so that the more we can collaborate and communicate with each other, again, I hate to say this, but the better off we all will be. So that would probably be my key takeaway there.
And I'd like to turn back to Doug and to Steve just for a minute, because recently the FBI issued a warning about unpatched and outdated medical devices, and they talked about cybersecurity opportunities to hackers. We see a lot of this coming out from time to time, particularly focused on medical devices from a patient safety perspective. I know, Denise, you had mentioned this when you were at the congressional testimony several months ago, but I wanted to start with Doug and Steve first to see if you could really talk to the concern regarding medical devices and what can and should be done to address the security concern. And then Denise, will turn it to you once Doug and Steve get a sort of a first stab at this question.
I'll start from a very clinical perspective. I mean, many devices that we use are critical for patient care. And I would say pre-cyber attack, I used to be like, look, it's so important to have this device work. And if the software is just not right, let's try and just mitigate the risk. I don't feel like that way anymore. Now I feel like, look, it's on that device manufacturer's their responsibility to make sure these devices are safe. And one device that we're using could shut down the whole system potentially again, right? Once they have that portal in. And so I think in the past, I took more of a clinician's perspective, like we just have to have this. And now I'm much more, well, if the device manufacturer can't give it in a way that we feel that we're confident is secure, we're not using it.
So that's unfortunately not quite true. Because in many cases, there's no alternative. There's high clinical value and there's just not a viable alternative. So we still regularly have to mitigate those cybersecurity risks, unfortunately. That's true now, is even more true in the past. So we've got devices in our environment that, you know, certainly don't meet our security requirements today. But even, I mean, it's not, I'd say once a month, maybe not that much anymore, maybe once a quarter, we still get a request for a device that fails our security review. And then we have to really have that conversation with the business. Are we willing to take the risk? We will do everything we can to mitigate the risk, but it's still a risk. And are we willing to take that risk? Is the clinical value high enough? So it's a challenge for sure.
Thank you, Doug, for the clarification. I appreciate that. But I do know I've been in meetings where we haven't bought something the clinicians really wanted because it did not meet your security needs. And we say, no, we're not buying that. Even when they said it was best in class, whatever, we said, no, we just can't do it. I do understand that we have things that are historical that we are still using. But even those, I've seen you guys build walls around them to try and make it safer.
Yeah, so it's a different conversation than we had previously for sure, but it's still a big challenge.
Denise, do you have any thoughts in terms of this question for the medical devices?
So yeah, it is a very difficult and I think very unique problem to healthcare with medical device security. And medical device manufacturers have come a long way. They're starting to talk, especially the bigger ones, building security in from the ground up, and they're focused on that, the SBOM, the whole security bill of materials movement. And patching is hard, right? Because you're in a 24/7 environment, and taking some devices offline can be a struggle. We are doing some things through the ISAC and, working with FDA and CISA and others about responsible disclosure, so that when a vulnerability arises, there is a way to communicate that very broadly with the sector so that they can take the appropriate actions that they need to do within their environments. I don't think that it's going to go away. I'm preaching to the choir. This is just a really big problem within healthcare. But I actually want to even say that it's bigger than healthcare, in that when we're relying on open source software and that's no longer being supported, that's another issue. And that side of the IT infrastructure, the software side, is one that I don't think we've adequately addressed from a compliance or regulatory perspective, because what we're finding is that you put a device in place and it's relying on an operating system that goes out of date within a couple of years, and that's not sustainable in many ways. And as we're, healthcare has been a little bit behind in connecting to technology. We're seeing the same thing with automotive. What happens in a couple of years when that operating system in your car is no longer supported? This is something that I think we need to tackle better as a collective critical infrastructure society, and I think we're going to be forced to deal with it at some point.
I'll second that. That is a big challenge for us, given we have thousands of medical devices and different things that connect, and going out of support and not getting any security updates is a constant challenge.
Chris, I think we'll start with you in terms of the next question. And Tina, feel free to jump in here because I know you're really one of the national leaders in terms of policy in this area. But there has really been an impressive leap, from my perspective at least, in terms of the use of what we call emerging technology in healthcare, whether that be machine learning or a lot of work that's being done with respect to artificial intelligence, and really changing the processes that really can revolutionize healthcare. Now, while some feel the technology is great, of course, security has to be addressed. And in keeping up and keeping pace with some of these trends, do you feel that the industry needs to really take the technological growth with moderation? Do you think that, this is sort of the path forward and we have to just accept it and move forward? Or do you think that progress really needs to be moving either slower or faster than security can keep up?
Sure. I think the emerging technology is the future direction and the business direction. So it's going to continue to evolve, and we need to be in front of it. We need to be alongside the business to help drive it, because if not, they're going to build insecure systems. It's going to cause a lot of angst and potential breaches. And if we don't partner with the business and understand the business need, translate it into risks that they can understand and solutions that we can help partner and build with, it's going to turn into a disaster, right? We need to think like a hacker. We need to be able to anticipate what and how things can go wrong. We need to understand the business use of the new technology and make sure that we have alignment with our various key stakeholders in the organization. So legal, privacy, audit, et cetera, and information security, working with the business to understand all those risk angles to make sure that we all come to the table supporting the business, but being the parent and helping them so they don't get into trouble down the road.
Doug, what do you think?
I basically agree with that. I don't think I have anything to add.
Steve, anything to add?
That was well said, Chris.
Denise?
Yeah, it definitely is the way of the future. I don't know that we could stop it, but I agree we need to get in front of it. And I think what's happened from the past is that we've always been behind. And so we need to make a concentrated effort to really understand the risks that these new technologies are posing to us. I mean, look at with DNA. We just had our summit in Phoenix, Arizona last week, and our keynote was a futurist who is very involved in medical, future medical technology. And she brought up a lot of really great points, such as DNA, being able to temporarily change DNA, to permanently change DNA, what the implications of that are. She touched on AI and some of the other things there. So it is something that we need to be looking at, absolutely. And I think we need to be looking at it with a lens on that looks at risks and the potential threats to us as a society, quite honestly, not just patients, and the ethics involved around all of it.
Denise, I thought we'd start with your perspectives in terms of apps. We talked about it in the last segment of our panelists today. And, the introduction of apps really have been on a big uptake in terms of the patient experience. Individuals are using them for a lot of things like tracking their sleep patterns, maybe managing chronic conditions like diabetes, et cetera. And that can be great in terms of integrating with your medical record, but it can also open the door to cyber criminals. So do you have any suggestions about what can or should be done for education of patients so that they get more accessibility to the data, but also understand some of the cyber and security risks that they may be facing?
Yeah, that's a challenge, and I think it's a generational challenge as well, because I find that the younger generations are much more open to pushing their data out there. They don't really understand the risks and the implications of losing your data or the control of your data. And then the older population may not understand it as well. Like my dad just actually had a device implanted in him So that was interesting to watch, that he'll be able to control with the remote. So I think it's an education, and unfortunately, I don't know, some people will buy it and some people won't. And those that probably, it's until they get bit, unfortunately, that they'll understand why it's so important to take control of the data, especially when it comes to your personal body or your family's personal bodies. So I'm not sure, to be honest with you, how to really tackle that other than through education and having people really understand the impacts. And maybe it's something where, people who have been impacted by it actually come out and speak about it, and we do some kind of public campaign at some level, whether it's through government or through industry, but making people really aware of the risk to them as individuals, not just immediate risk, but long-term future risks as well.
Do any of our other panelists have any thoughts to share on this question of apps and the patient experience?
I'll just say, there's a balance between ease of use and security. And ease of use, probably you're more concerned about it until you have a problem, right? You don't know what the problem is until you've experienced it. And so I think that public education is probably important, but I think a lot of people download apps without having any idea where the information's going, what it looks like. Whoever reads all that giant thing that comes with it, right? So I think that probably, once again, I'm a big believer, you have to protect people from themselves as much as possible and put in supports and guards behind the scenes for a lot of that work.
We've actually worked on this a bit from a policy standpoint. WEDI and the Confidentiality Coalition sent a letter up to the Department of, HHS, as well as the Department of Commerce, about instituting a certification process for security as it relates to apps. And it was really interesting in doing our research and writing our letter and talking with CMS in particular, because of these requirements now that CMS and ONC are putting on providers and plans to upload information, into apps through APIs, is that CMS has its own security standards for the Blue Button 2.0 program. They will not allow, certain apps or technologies to be used from a CMS standpoint if they don't meet certain security standards. So we've been advocating at the policy level that, there be some sort of a certification process so that we can be sure that these apps are at least as secure as CMS requires its apps. And CMS did tell us, this is a few years ago now, but that they hadn't had any serious security issues to date. So I don't know if that's still the case. It would be interesting to know 2 years later if that's still the case, but it is definitely sort of, from the app world, kind of a bit of a Wild West out there, definitely.
Yeah, it is totally a Wild West. And honestly, the ONC requirements, the information blocking requirements, have made it worse because we're required to provide that connection. We don't have any we can't say, oh, that doesn't look secure to us, or nor do we have the resources to thoroughly vet all of these. So it's a problem. And I don't think it's a problem we as individual provider organizations can solve, particularly when we're mandated to connect to those third-party apps if the patient requests it. So
ONC just put out a blog this afternoon on privacy and apps. It looks like, I haven't had a chance to read it yet, but it came out during our webinar here.
As we start to come to the close of our time together, Denise, I wanted to turn to you quickly to talk about zero trust architecture. It's really been touted as a solution and as a resource. I know that some folks are still in the process of learning about it and what it is. And the HISAC has put out a white paper recently. I was wondering if you could briefly walk the audience through what zero trust architecture means and how it can support cybersecurity.
Sure. So we do have a paper up on our website, and we also have some others around identity and access management. And Zero Trust was tied to those papers. So basically, the concept of Zero Trust is that all individuals and devices on a network be continuously authenticated, authorized, and monitored. And that really comes down to, instead of securing the perimeter, it's a matter of securing the user. And it really looks at granular control enforcements to access. And one of the challenges that's very unique to healthcare is that we have, as we've mentioned previously, tens of thousands of IoT type of enabled devices in provider and other environments that need to be secured. And then there's also the issue of moving from room to room and data moving from environment to environment. So those are unique to healthcare, and those are concepts that hopefully Zero Trust can help with. And of course, it's just looking at, again, securing the access, the user at a very granular level.
So in the last few minutes that we have together, I thought, Chris, we could start with you. If you could give the audience your top 3 takeaways that you should leave them thinking about as, we move into the new year and look on the horizon in terms of solutions. What are you concerned about as we enter the new year, and what are sort of your top 3 takeaways that you want to leave folks thinking about?
Sure. So quickly, top 3 takeaways. I mentioned before, don't go hunting a unicorn. You're not going to find it. Find a person that has got enthusiasm, a willingness to learn. You can always train them, right? Be open to people maybe from non-traditional security backgrounds that can bring a new perspective to the organization and your projects, et cetera. Focus on covering your bases, right? Go back to the basics. Look at your security program, do some gap analysis, figure out, based on your attack surface and your controls, what's working, what's not, what should be improved. Prioritize it, right? Chip away at it, make incremental improvements throughout the process. And then the last one would be around risk. Let risk be your guide, right? Everything should be translated into a risk kind of mindset. It should be something that helps you prioritize your investments, helps you to communicate to the business, and hopefully drives change, right? Because people can understand that, and it shifts away from a security-minded conversation, which is applicable in certain areas, but not from an enterprise perspective.
Doug, same question to you. Oh, I'm sorry, Chris, go ahead.
That's fine. Thank you.
Doug, same question to you. Top 3 takeaways, and what are you thinking about and concerned about as we're moving to the new year?
I think, Doug, you're muted.
Sorry about that. So from a provider organization perspective, I think you have to assume you're going to get hit. I mean, we get attacks every day. And so making sure cybersecurity is a high priority. It's, as Steve and I alluded to in the past, it really often got pushed aside because of other priorities. So, and that making that a high priority has a lot of behind that. Second, again, assuming you're going to get hit at some point, make sure you have good business continuity plans in place. That's really an operational task, not an IT task per se, to make sure that, if you do get hit, that you've got the processes in place to be able to continue operating successfully. And I think, again, the last thing I would say from a healthcare provider perspective is, look at your cybersecurity insurance, because if you do get hit, it's a tough situation out there. So, you want to review that, make sure you're covered to the extent that you can be covered.
Steve?
Doug and I must work together. I had almost the exact same 3. So number 1, I said, assume it will happen. Have a plan, but adapt depending on the circumstances you find yourselves in, and invest in protection to the best that you can and keep it current.
Great. Denise, how about you?
Same kind of message. The threats are not going to go away. They're going to evolve. Have an enterprise risk management perspective with an operational resilience mindset to that. And you're not alone. Rely on your peers, your communities to share and collaborate and communicate with each other.
Well, this has been very helpful from my perspective, and I want to thank all of our panelists. Tina, Is there anything that you wanted to ask in the time that we have remaining?
No, it's been just a fascinating conversation. And again, to Steve and Doug, thank you so much for sharing what happened to your organization and being so, upfront with everybody. Those are the kinds of, lessons that are so helpful for the rest of the industry to learn from. And Chris, Denise, wonderful. Yes, thanks to everybody.
Thank
Well,
you.
and just as a reminder to everybody, I do want to reinforce the fact that WEDI is going to be hosting a virtual spotlight on January 31st. Denise mentioned the Zero Trust, and that spotlight will be focusing more in terms of Zero Trust identity strategy and how that can help protect patient data. So for those of you who are with us and who are interested in that, certainly encourage you to check out that event and sign up for that as well. So thank you all to everyone. We've reached the end of our time together, and I also want to thank Michael McNutt for doing such a wonderful job in terms of preparing us for today's discussion and doing all of the technical infrastructure and everything else that it takes to get these spotlights up and running. So thank you to Michael. Thank you to all of those of you who have joined us for our time together. We hope that you find it informative. And just as a reminder, we will be sending the slides and a recording of today's event once the event has concluded. So thank you all for joining us. We are adjourned.
Thanks, Marilyn.
Thank
Thanks,
you.
everyone.